Good evening, everyone. Welcome to the continuous professional development activity organized by Sri Lanka College of Specialist Family Physicians. Uh, Before we start, I would like to give some housekeeping rules. Please make sure to rename yourself with the Zoom name similar to that should appear in the participation certificate. Towards the end of the lecture, a link will be shared in the chat box. Please fill out the provided form. Note that the attending the session for minimum of 45 minutes and completing this form are necessary to obtain the certificate. The certificate will be sent to you via email within 1 week. Please keep your microphones muted and videos off throughout the session. If you have any questions, kindly type them in the chat box. They will be addressed later. Today, we have an esteemed resource person, Dr. Pubudu Amarasena, who obtained his MBBS from Faculty of Medicine, University of Colombo, and MD Medicine from PGIM, University of Colombo. And currently, he's a consultant neurologist and clinical research fellow in headache at King's College Hospital, London, United Kingdom. So I invite Dr. Pubudu to start the session. Sir, over to you.
Thank you very much. I don't know whether you all can hear me properly.
Yes, sir, we can hear you.
Thank you very much. And thank you very much for the Sri Lanka College of Specialist Family Physicians for inviting me for this talk, and also to Dr. Prabhat and Dr. Asika for coordinating this talk. So I'm going to speak about headache disorders in clinical practice. So whichever field we practice, headache is going to be a common problem, and there'll be a lot of people presenting with headache. So it's quite important to properly assess the headache patient. Most of the time it will be migraine, but there will be a few patients who will have a life-threatening condition, and while picking these patients up, you can probably save a life as well. I don't have any disclosures. Only thing is I have been a migraine sufferer myself for many years and have had my medication overuse as well, so not a good patient. Before I start, I'd like to know what kind of an audience we have. I'm going to, there is a QR code if you can scan, and I'm going to share a link if you someone wants to share, connect with the link as well. So if you can scan this, you will, yeah, if you can pick what your role is, just for me to get an idea about what you do. Select the option and then click submit as well. And during the presentation, I will have a few cases. I'll be using the same format to get the answers. This is all anonymous. I don't know who's voting, and just want to check if this works properly. You can see that 14 are logged in at the moment. I'll wait a few seconds more. Right. So we have basically a lot of registrars from family medicine and essentials. Okay. Good. Now, before I talk about my objectives for this talk, I'd like to know what you expected from this. So again, let's see what you wanted to see. It'll be the same QR code for. You can be honest. Okay. Right. So we'll move on. So just want to check if this works for the rest of the presentation. Right. So those are your objectives. My objectives, I'll first introduce headache disorders, give a brief introduction to headache disorders. Then we'll go through how to assess a headache patient, and then we'll go through some of the common headache presentations that we see in our clinical practice. So when you look at the classification of headache disorders, we divide them basically into primary headaches and secondary headaches. So secondary headaches are any headache that uh, happens due to a secondary cause, something like infections, tumors, bleeding, so trauma, anything which causes a headache, we classify them as secondary headaches. Primary headaches are when there is no secondary cause. So the commonest one is migraine, and you have tension type headache. And there's a third group called trigeminal autonomic cephalalgias, which includes cluster headache, paroxysmal hemicrania, hemicrania continua, and this other group called SUNCT and SUNA, which is short for short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing. And SUNA is short for short-lasting unilateral neuralgiform headache attacks with cranial autonomic symptoms. And then there are a few other primary headache types as well. Now, when a patient comes and tells you that they have headache, the history is the most important. In neurology, we put a lot of emphasis on our neurological examination, but when it comes to headache, the history is the most important. And proper history is very important to get the proper diagnosis and to plan the management. And also, this could save a life if you pick up the more important ones. So, as in any pain assessment, you take the normal history, site, onset, the character, radiation, associated symptoms, the normal history that you take in any pain in patient presenting with pain. Now, something more important in migraine, in headache, is you need to look for red flag signs. So these are the signs that will tell you that there could be something serious going on. In the past, we considered early morning headache or waking up with headache, or headache worsening with bending down as very sinister symptoms. They can be, but even migraine patients will tell you that they wake up with headache. They can be woken up in the night with headache, and their headache will get worse even if they bend down. So there are more important red flags to look for. And this mnemonic SNOOP10 is a common mnemonic that's used to remember these red flag signs. So the common things that you need to look for are systemic symptoms like fever, which could tell you that there can be a more systemic problem going on. History of cancer or neoplasm in the patient, where you need to look for any brain metastasis or brain lesions. Neurological deficit, onset of the headache, where there is a very abrupt onset. When the patients are older, you have to think about certain things like giant cell arteritis, a recent pattern change or a recent onset headache, positional headache, where the headache gets worse when they're lying down, or the headache gets worse when they're standing up. Effect of Valsalva maneuvers like sneezing, coughing, bending down, straining. And on examination, if there is any papilledema, progressive headache, atypical presentations, patients who are presenting with headache in their pregnancy, around puerperium, painful eye with autonomic symptoms, post-traumatic onset, any history suggestive of immune deficiency, or medication noise. So these are the common red flag signs that you need to look for in any patient presenting with headache. In addition, you need to look for some specific associated symptoms. So one thing is focal neurological symptoms and signs. And then you have to look for aura symptoms, especially in patients who have migraine will come and tell you that they have, prior to headache, they will get vision changes or some sensory disturbances, different other symptoms. So those you need to look for. And also cranial autonomic symptoms are also something that's quite important in headache patients. So cranial autonomic symptoms are symptoms that are mediated, are due to parasympathetic uh, activation in the face and the surrounding structures. So common cranial autonomic symptoms, when you look from the forehead, you can get forehead sweating, facial flushing, meiosis, lacrimation, conjunctival injection, eyelid edema, and partial ptosis. And they can also say their eye feels gritty and itchy. When it comes to the nose and the ears, you can get blocked nose or rhinorrhea. Their ear can feel blocked and there can be a red ear. And also they can have throat swelling and voice change. And all these are because of autonomic activation. So some of this you will experience if you eat a lot of spicy food also, you experience this. And similarly, these can happen when you in some of the headache disorders as well. So it's important to look for these in any headache patient. And then premonitory symptoms and post-ROM symptoms. So premonitory symptoms are symptoms which occurs prior to the onset of the headache, and post-ROM is what the patient feels after the pain has settled. And then triggers, especially you need to look for the effect of Valsalva maneuvers and the posture, whether when they're lying down or sitting up, if that makes a difference to the headache. And you need to look for family history, especially of migraine. And medication history is important when you plan treatment. What are they using at the moment, and what medications they have used and failed in the past. So we'll do a small case. These are not complicated cases, just to keep you involved in the talk. This is a 34-year-old female presenting with sudden severe headache for 3 hours. She says that this is the worst headache ever. Pain was maximal within 2 minutes, and she also has a history of infrequent migraine. So in a patient presenting with similar symptoms, what kind of conditions will you consider? So again, if you can scan the QR code, it'll be the same QR code. If you can rate what you think, select conditions which you think we need to consider in these patients. Right. So most of you thought subarachnoid hemorrhage very correctly. And in addition to subarachnoid hemorrhage, the other things to consider are cerebral venous sinus thrombosis, pituitary apoplexy, carotid artery dissection, and reversible vasoconstriction syndrome. Now, this presentation is what we call a thunderclap headache. So in thunderclap headache, these conditions, subarachnoid hemorrhage, venous sinus thrombosis, pituitary apoplexy, carotid artery dissection, and reversible vasoconstriction syndrome, all of these can present with thunderclap headache. And the most sinister one is subarachnoid hemorrhage and cerebral venous sinus thrombosis are the ones which you need to exclude. Now, I think someone has drawn on the screen I can. Yeah. Now, thunderclap headache. So when you say thunderclap headache, there's a very defined definition for this. Thunderclap headache is very abrupt onset, very sudden onset headache, and the patients will come and tell you that this is the most severe headache that they have experienced in their life. And it's very important to characterize how the headache started. So in thunderclap headache, when you say thunderclap, the pain will be maximal at the onset and within the first minute, and the headache will go on for 5 minutes. Sometimes when you ask patients, they will say this the headache was the worst at the onset, but then you ask them again, they will say headache was worse, but then after several hours, the headache got worse even more. So that wouldn't classify. Uh, we wouldn't classify them that as a thunderclap headache. For thunderclap headache, the maximum should be within the first minute. And the common causes, as I mentioned, are subarachnoid hemorrhage, reversible cerebral vasoconstriction syndrome. And the less common ones are cerebral venous sinus thrombosis, pituitary apoplexy, and cervical artery dissection. Now, the same patient, after she came to the emergency department, a CT scan of the head was done, and which was reported, and the CT scan was done in about 4 hours from the onset. Now, how many of you would uh, arrange a lumbar puncture for this patient? I mean, we are looking for xanthochromia to see if there has been a subarachnoid hemorrhage. So if the CT is normal and done within about 4 hours, how many of you would do a lumbar puncture? Think there's a problem in the, you can't see the responses. Uh, right. In this situation, a lumbar puncture is not really indicated. Now, when you look at how to investigate a thunderclap headache, so any patient, if you classify the headache as a thunderclap headache, you need to do a plain CT head first. So if that confirms a subarachnoid hemorrhage, then the management is basically through the neurosurgeons. You need to refer them for further investigations, and if they identify an aneurysm, they will plan for either clipping or coiling of the aneurysm. And so that we will leave to the neurosurgeons. Let's say the CT scan was done but was reported normal. Then what do you do? So the current guidance is that if the headache was done within 6 hours from the onset, and if it was reported normal by your radiologist, then you don't need to do a lumbar puncture routinely. But you can always use your clinical judgment, and if you think there's a very high likelihood of subarachnoid hemorrhage, you can still go ahead with the lumbar puncture. But you don't need to do a lumbar puncture as a routine if the CT scan done within 6 hours was normal. But if the CT scan was done after 6 hours and was reported normal, you have to go ahead with the lumbar puncture. And the lumbar puncture has to be done 12 hours after the onset to look for xanthochromia. And the xanthochromia can be positive up to 14 days from the onset. If for any reason, if the lumbar puncture can't be done, you can go ahead with a CT angiogram or an MRI angiogram to look for any signs of a hemorrhage or the presence of an aneurysm. So if it is not a subarachnoid hemorrhage, the possibilities are it could be some of the other conditions that we mentioned. But if everything is negative, it could be a reversible cerebral vasoconstriction syndrome, where you have vasoconstriction giving rise to thunderclap headache. You can pick it up when you do a angiogram or a DSA, and it is reversible. So it when you repeat the scans in about 3 months, the vasoconstriction has resolved, and sometimes RCVS can recur as well. So this is basically about thunderclap headache. So main thing is to identify the thunderclap headache and to plan the initial investigations. You can plan the management depending on what you find. Now, let's go on to primary headache disorders, and migraine is the most common primary headache disorder that we experience in our clinical practice. Now, before we talk about it, how many of you have migraine? Again, the same QR code. You have someone who's never had a headache, quite lucky.
Excuse me, sir. Is it
Yeah.
possible to post the link again to the chat box?
Yeah, sure.
Thank you, sir.
You can use the QR code at the on the slide as well, but I put the link as well. Yep. So we have about but 5% of the audience who have never had a headache. You can say that you're quite lucky. And some with episodic migraine and chronic migraine as well. Good. So if you have migraine, then you will know what I'm going to talk about in the next few slides. Right. So migraine, it's not just a headache. It's not just pain. So if you have migraine, you will know that there's a lot of other associated symptoms that can be associated with a migraine attack. Now, migraine is usually and commonly it's quite a misunderstood problem, and it doesn't get the attention that it deserves. In the global burden of disease study, migraine is one of the top 3 most disabling neurological conditions. And in children, adolescents, and women of childbearing age group, it's a number 1 disabling neurological condition according to the global burden of disease study. So migraine, so we all think it's just a headache, but there are several stages of a migraine attack. So there is a premonitory phase, followed by a headache phase and a postdrome. And in between the premonitory phase and the headache phase, there can be an aura in those who get migraine with aura. So aura doesn't happen in everyone, only in a certain number of patients with migraine. So the premonitory phase, it happens about it occurs prior to the headache phase, and it can precede the headache by up to 3 days. So patients with migraine, they will know that they are going to get a headache tomorrow or in several hours because of the certain symptoms that they start experiencing. So common symptoms are yawning, neck stiffness, sleep disruption, concentration difficulties, irritability, mood changes, and they start craving for carbohydrates, sugar, and they will feel a lot of fatigue as well. Now, commonly in the past, we considered things like chocolate to be a trigger of migraine. But our current understanding is that these are not actually triggers. It's the premonitory craving that leads to eating more chocolates and sugar and carb products. And and people assume that it's because of the chocolate that they got the headache, but it's the opposite. Because of the migraine premonitory symptoms, they start eating more. So that is more evident. When a patient doesn't have a migraine attack, chocolate doesn't always trigger the headache. So that's why I think it's a more premonitory symptom of craving rather than chocolate triggering the headache. Now, when you look at some of these symptoms that you experience in the premonitory phase, like yawning, sleep deprivation, polyuria, craving, these are hypothalamic symptoms. So functional studies have shown that in the premonitory phase, the hypothalamus is overactive. So at the current understanding is that the migraine attacks are possibly originating from the hypothalamus. Then comes the aura phase in those who have migraine with aura. So aura can be visual aura, which can be flashing lights, zigzag lines, a scintillating scotoma, or black spots. And then there can be sensory aura, where you get pins and needles sensation starting from the fingertips or in the face and kind of spreading over several minutes. Motor aura is hemiplegic aura, where you get the weakness on one side. Language aura is dysphasia, patient have difficulty finding words. And brainstem aura, and they get brainstem symptoms like vertigo, double vision, dysarthria. Now, one problem we have, especially in the emergency department, when a patient comes with an aura, is whether this is an aura or is it a stroke. Now, there's no concrete way to differentiate the two. You have to always think about stroke, and if there's even the slightest suspicion, you have to investigate for a stroke. But there are a few things that can help you to differentiate between the two. One thing is, stroke is very abrupt onset. They will get the symptoms will start very suddenly, whereas in migraine, the symptoms will develop over a few minutes. So there can be, so if it is vision, they get this scotoma, and it will spread gradually over 15 to 20 minutes, and then it will improve. And paresthesia is also the same. They get the tingling starting from the hand, and then gradually go up the arm and into the face as well. And another thing that helps is stroke usually tends to be negative symptoms. You get numbness, weakness, difficulty speaking, hemianopia, that kind of symptoms. Whereas in migraine, except in hemiplegic aura, it tends to be more positive symptoms. You get flashing lights, bright lights, or numbness, or tingling sensation rather than numbness. So that can also help a little bit to differentiate between the two. And also, if there are vascular risk factors, you have to always think about stroke. Again, there's no concrete way to differentiate between the two. You have to always think about stroke and investigate if you think it could be a stroke. Now, headache phase, the headache is usually more on one side, but can be usually generalized, but more on one side. It has a throbbing or pulsating character. And the headache can go on for 4 hours, even up to 3 days. And the headache is moderate to severe, and it's worsened by routine activity, and the patient can't continue with their normal activities. And the associated symptoms are nausea, vomiting, and they become sensitive to lights, sounds, movement, smells. And there's cranial allodynia, where if you touch the scalp, that's quite tender. And in migraine also, there can be cranial autonomic symptoms, but they tend to be more bilateral. So you can get bilateral tearing, bit of nasal congestion, bit of runny nose as well. So my autonomic symptoms are not uncommon in migraine. And once the headache settles, the patient then have the post-room, which can go on for another day or two. So in this period, although they don't have the headache, they will continue to have fatigue. They will feel drained. They feel like they've had a hangover. They feel lethargic. So and concentration difficulties. All these can continue for another day or two. So when you look at the whole picture, it's not just the headache. The migraine attack can go on for several days and can have a significant effect on the day-to-day activities, especially when it becomes chronic. Now, I'm not going to go into detail about migraine pathophysiology, but I need to tell a few things because it is important when we discuss about the treatment, because there has been a lot of new developments in migraine treatment over the last few years. Now, we know in migraine pathophysiology, the trigeminal vascular system plays a big role. That includes the meninges and the intracranial blood vessels, and the trigeminal afferents, and then the trigeminal ganglion, and then the trigeminal spinal nucleus. The trigeminal spinal nucleus, along with the upper cervical dorsal root ganglion, forms a complex called the trigeminal cervical complex. So we know in migraine, the dural nociceptors are activated, which then results in the activation of the trigeminal cervical complex. Now, within this system, there are several neurotransmitters that we have identified, and one of them is substance P, and there's one of the more important one is CGRP, which is calcitonin gene-related peptide. And there's another new molecule that has been identified called PACAP, which I will tell later. So studies have shown that during a migraine attack, the CGRP levels are elevated. So that led to development of medications targeting CGRP pathway, mainly CGRP to block the CGRP activation. So that had made a big difference to the migraine management over the last 5 years or so. I'll talk about CGRP medications as we go along. So migraine treatment, there are two aspects of migraine treatment. There's acute treatment and preventive treatment. Every patient with migraine should be given acute treatment. And preventive treatment is usually indicated if they have more than 4 or more migraine attacks a month. So acute treatment, we can use simple analgesia like paracetamol, ibuprofen, aspirin 600 to 900 milligrams, or naproxen, along with triptans. So triptans are 5-HT1B, 1D agonists. These are serotonin receptors which are found in the trigeminal cervical complex that I showed before. And commonest triptans that we use are sumatriptan and zolmitriptan. There are 7 triptans. In Sri Lanka, at the moment, we only have sumatriptan and zolmitriptan. Sumatriptan also, I think recently it has not been available. Sumatriptan you have as oral tablets, subcutaneous and nasal, and Sri Lanka we only had the oral tablet. But zolmitriptan is quite widely available in Sri Lanka. You have the oral tablet as well as the nasal spray as well. Other ones are not available in Sri Lanka. And patients can use simple analgesics along with the triptan as well. So you can combine the two if needed. And we also usually give an antiemetic because one reason is they get the nausea because of the migraine. And also there is the gut motility is reduced during migraine attack. Because of that, the medications don't get absorbed properly. So because of that, we give an antiemetic as well. And for triptans, there are certain contraindications. One of the side effects of triptans is vasoconstriction. Because of that, you can't give it in patients who have ischemic heart disease, uncontrolled hypertension, any other vascular risk factors, and also patients who have sulfonamide allergy, you can't give triptans. And opioids are generally not good for headache because that leads to dependence, and then medication always becomes a big problem. So we don't usually recommend to give opioids. And for patients who have not responded to triptans, there are other new medications available. There's one called rimegepant and lasmiditan. These are unfortunately not available in Sri Lanka, and even in the UK, lasmiditan we don't have. Rimegepant we use at the moment. I'll talk about it a bit later. Now, when it comes to preventive treatment, these are the conventional preventive treatments that we use. So we use beta blockers like propranolol, metoprolol, antiepileptics, topiramate, valproate, ACE inhibitors. Candesartan is quite a good migraine preventive. Antidepressant, amitriptyline, nortriptyline, and venlafaxine. Pizotifan is also used. And then flunarizine is a common one, which is used in Sri Lanka a lot. And melatonin, which is used for sleep, it can be used as a migraine preventive as well. And studies have also shown riboflavin and magnesium and coenzyme Q10 could have a modest effect on migraine. Now, commonly used ones are propranolol, candesartan, amitriptyline, nortriptyline, and flunarizine. I put topiramate and valproate in red because of the risk of teratogenicity. In the UK, we can't it's quite difficult to prescribe topiramate and valproate to women of childbearing age group. We had to do a pregnancy prevention program and get it signed. So we don't usually use these for migraine prevention at the moment. Right. Now, once these medications, these are not migraine-specific treatment. These are developed for other indications, and then we found that they are effective for migraine. Whereas the new treatments that's available, these are especially the CGRP medications, they are migraine-specific treatments that are developed for the treatment of migraine, and they're actually quite effective. So CGRP medications, these are CGRP blockers. So we have monoclonal antibodies and the GPANs. So GPANs are oral tablets where you take. So atogepant is a daily tablet. Rimegepant is an every other day tablet. And the monoclonal antibodies are given as subcutaneous injections once a month. Erenumab, fremanezumab, and galcanezumab, they are once a month subcutaneous injections. These are in the UK. They are delivered to the patient's home. They do it on their own at home. It comes in a self-injector. And eptinezumab is an infusion. You have to give it once in 3 months. It needs hospital admission. Unfortunately, none of these are available in Sri Lanka at the moment, but I assume some of you will be going for your foreign training, so it's good to know about these things which will be available when you go for foreign training. And botulinum toxin is another treatment that we use. So for migraine, we use 31 injections around the head, which has to be repeated every 3 months. This is available in Sri Lanka, and there are some neurological consultants who do it in the government sector as well. And yeah, so these are the ones which can be used for patients who have not responded to conventional migraine preventives. And something that has come up recently is another molecule called PACAP, or pituitary adenylate cyclase activating polypeptide, which is again a neurotransmitter like CGRP, which is found in the trigeminal cervical complex. And a recent phase 2 trial has shown that this medication targeting PACAP can be effective. So new phase 3 trials will be coming up soon as well. This is just to give you an idea about what's coming up and what has been the recent change. Now, these medications are quite effective. CGRP-based medications, almost 60% of the patients find them quite effective, and they don't have any side effects. The commonest side effect people complain are constipation. And so it has been a real game changer for the migraine management in the last 5 years. So when it comes to migraine prevention, usually we start with the conventional migraine preventives. You need to take account of their other comorbidities, whether they have high blood pressure, asthma, and then find a preventive that's suitable for everything else. And usually we see that once patients are prescribed a preventive, they on the same dose for months and months without getting a good benefit. But if you're managing migraine properly, the dose has to be titrated depending on the response. Usually we ask the patients to do the titration by themselves. So if you start propanol, we say if you have headache has not improved, in 2 weeks, increase the dose to 40 milligrams. And again, to increase as we go along, and we give the target dose. So before you decide a medication is effective or not, they need to have tried the highest tolerated dose or the target dose for at least 8 to 12 weeks. If that has not been effective, then you change it over to a different preventive to find something that works. So patients who have not had a good response to 3 or more preventives, then you go on for the new treatments. Unfortunately, in Sri Lanka, we only have the botulinum toxin, but in other countries, we can use CGRP monoclonal antibodies for these patients, for refractory patients. Greater occipital nerve blocks are another treatment that we use as a kind of like a bridging treatment. We give a steroid plus a lidocaine combination to the greater occipital nerve. If it is effective, it can be effective for up to 3 months, and it can be repeated again if needed. And it's a quite good treatment for, especially in pregnancy as well, because there are no side effects from it. So we usually manage pregnancy with one injections. And there are neuromodulation devices, electrical devices. None of them are available in Sri Lanka. We have trigeminal nerve stimulation. We have vagal nerve stimulators, magnetic stimulation, and remote electrical neuromodulation is a device, electrical stimulation device that you put on the arm, kind of use of the gate theory in pain to manage headache, manage the pain. I'm not going to go into detail. This is just a suggestion based on what we normally practice. I will share this so you don't need to copy this down. So this is how you start the dose and then titrate and increase up to maximum dose, and certain things that you need to consider when you prescribe these medications. I will share this later, don't worry about it. So that's about migraine. And another type of primary headache disorder is tension type headache. Now, there's a bit of a doubt whether tension type headache is actually a milder migraine, but it is there in the international classification of headache disorders. So tension type headache, usually if it is tension type headache, patients generally doesn't need to come to the hospital or to see a doctor because it's a mild headache, which would usually settle with simple painkillers. So if someone comes to see a doctor, then you need to see whether this is actually migraine. And if you dig deep into the history, most of the time you can find something to suggest that there is some migraine biology going on. But generally, tension type headache can go on for longer. It's a mild headache. There's no nausea or vomiting. There can be one of either photosensitivity or phonophobia. And it's usually a mild headache. And treatment is usually you try amitriptyline, and but basically you treat it. If they need treatment, you can treat it as for migraine. Now, medication overuse is something that you need to keep in mind when you treat headache. So medication overuse headache usually occurs in a patient who has a pre-existing headache disorder, and they have headache more than 15 days a month. This happens when they regularly overuse painkillers. So the cutoff for this is for simple painkillers like paracetamol and NSAIDs. Medication always becomes a problem if they use it more than 15 days a month. For triptans and opioids, it becomes a problem when they use it more than 10 days a month. So you have to always, when you prescribe acute medication, you have to always tell the patient that this can be a problem and make sure that they understand they should not overuse. Now, if a patient is already overusing, then managing the headache becomes a bit of a tricky situation. So one main thing is education, that overusing medication can complicate the headache management. So once the patient understands that, it is a bit easier to manage this. Now, there are several ways you manage medication overuse, and there's no correct way. So you have to tailor it to the patient. Some clinicians ask the patient to stop painkillers abruptly for 1 month, and then after that, after they've gone through the withdrawal, then they start a preventive. Another approach is to start a preventive and optimize the preventive, and then after some time, then start gradually withdrawing the pain medication. Now, both can be effective. Now, one problem with abrupt withdrawal of pain medication is then the headache can get worse, especially in the first few days. For triptans, for the first 4 or 5 days, and for opioids, for the first 10 days, they will have significant worsening of the headache. So a lot of people relapse and they don't continue with the plan. Some studies have shown that a combination approach is better tolerated and more effective. So you start optimizing the preventive and gradually start cutting down on the pain medication. This article that I put the link below has some information about this. This is written by some of my colleagues that I work with. So there's no one correct way to do it. So you have to tailor it to the patient and then find a method that works for the patient. But education is very important, that especially when you prescribe the acute medication. Right. Now for a break, let's do another case. So this is a 25-year-old male presenting with frequent episodes of very severe right-sided headache. He says it's excruciating pain. Each attack lasts about 2 hours and can occur 5 to 6 times a day. It can be associated with light sensitivity, nausea, and there is lacrimation from the right eye and right-sided nasal congestion. He's had an MRI scan of the head with contrast and an angiogram, which is normal. So what is the most likely diagnosis? Is it migraine, tension type headache, sinusitis, trigeminal neuralgia, or cluster headache? Let's see what you think. Right. So majority thinks it's cluster headache, which is the cluster headache is the correct diagnosis in this situation. So cluster headache belongs to the group of primary headache disorders called trigeminal autonomic cephalalgias. So as the name suggests, it's a headache disorder mediated by the trigeminal around the trigeminal region. Now, in this group, there are four main types of headache: cluster headache, paroxysmal hemicrania, hemicrania continua, and another group called SUNA, which involves SUNCT and SUNA both. Now, these types of headaches are rare headache types, and these are managed by neurologists. So if you can know when to suspect this, then you can refer them to a neurologist for further management. So when do you suspect attack headache? So we call them attack headaches for short. So if it is a strictly unilateral headache which has short attacks, usually it's seconds, minutes, and up to a maximum of 3 hours, depending on the type of the headache. So if it is short-lasting attacks, strictly unilateral, associated with cranial autonomic symptoms on the same side, that's when you need to suspect a trigeminal autonomic cephalalgia. I will talk about cluster headache as it is the more common one out of the attack headaches. So cluster headache, it's a very severe or excruciating headache, and it's also called suicide headache because people have committed suicide because of the severity of the headache. And it's a strictly unilateral pain which is around the retroorbital or the temporal region, and it can be associated with ipsilateral cranial autonomic symptoms and a sense of restlessness or agitation. So cranial autonomic symptoms, they will have tearing from one side, a blocked ear, blocked nose or runny nose, sweating on the face, or blocked ear on that side. And they can't stay still. For example, if a migraine patient will switch off the lights, close the curtains, and they'll go and sleep. These patients, they can't stay in one place. They will be rocking around. They will be pacing around the room. They will try to bang their head against the wall. So it's a very severe, excruciating headache. And the duration, it's usually 15 minutes to 3 hours, and it will settle on its own within about 3 hours. And patients can have about 1 to 8 attacks in a day. And there is a periodicity. So patients go on for, say, 2 to 3 months with daily attacks throughout the day. And then they suddenly go into remission, and there are no headaches for several months again until a bout starts again. And within a bout as well, the attacks tend to occur usually around the same time. Patients will say, usually it's in the night, sometime, and in the day as well. Patients will tell you that I get attacks around 1 in the night, another one at 4 in the morning, another one in early morning as well. So they know exactly roughly around when the attacks are going to happen. And periodicity in Western countries where there is seasonal change, we see that around the time of the seasonal change, the cluster headache attacks are more common, especially this time of the year in UK when the season changed from autumn to winter and then winter to spring. Around that period of change, a lot of people go into cluster headache bouts. We don't know exactly what's the cause of it, but I think it's a change in the cyclical pattern as well. So we don't know exactly why. Now, cluster headache treatment, acute treatment, the first line of treatment is high flow oxygen, which needs to be used with a non-rebreather mask. When they get attacked, they use it for 15 minutes, high flow oxygen, 15 liters per minute. In the UK, these patients are prescribed home oxygen, so they have a home oxygen cylinder at home to use it when they go into bout. But I don't think we have that facility in Sri Lanka. Another option that works quite well is subcutaneous sumatriptan injections, which unfortunately we don't have in Sri Lanka. An alternative is intranasal solmitriptan, which has a bit of a delayed action because it's nasal administration, but it can be effective as well. Prevention, first line of prevention is verapamil. In addition, we can use lithium, we use nerve blocks, we use melatonin as well. And prevention is only given when they are in a bout. So if once they come out of the bout, once the attacks stop, after about 2 weeks later, we stop the treatment and restart it again when the bouts, if the bouts start again. So these patients are managed by neurologists. So if you suspect a cluster headache, refer them to a neurologist so they can confirm the diagnosis and start treatment. Again, these are the other types of attack headaches. This is just for your information. You don't need to know all these. If you can know when to suspect attack headache, unilateral pain, short-lasting attacks with ipsilateral cranial autonomic symptoms, that should be enough. But the differentiation of these types is mainly based on the number of attacks and the duration of the attacks. So cluster headaches, 1 to 8 attacks, 15 minutes to 3 hours. Paroxysmal hemicrania, 1 to 40 attacks, 2 minutes to 30 minutes per attack. Hemicrania continua is, as the name suggests, it's a continuous headache on one side, with there can be worsenings through lasting 30 minutes up to 3 days. And Sangtan Suna are very short, sharp stabbing pain, can be 1 to 10 minutes. And people usually have hundreds of attacks in a day. It's very painful and quite disturbing for the patient as well. Cluster headache is triggered by alcohol, and Sangtan Suna have cutaneous triggers. So if you touch the certain places of the forehead, they can trigger these attacks. Now, treatment, cluster headache responds to oxygen and sumatriptan. Paroxysmal hemicrania and hemicrania continua have a very specific response to indomethacin. So they have almost like 100% response to indomethacin. So for diagnosis also is confirmed by giving an indomethacin trial. So indomethacin is available in Sri Lanka. So if you suspect, you can use indomethacin. Sometimes they don't respond to oxygen or indomethacin. The main mode of treatment is lamotrigine. Again, this is just for your information. If you suspect, refer to a neurologist. Briefly about trigeminal neuralgia. So trigeminal neuralgia is it's a sharp shooting stabbing pain in the trigeminal distribution. Commonest causes are neurovascular compression, where there's a blood vessel going across the nerve, and there can be secondary causes like MS and tumors. Trigeminal neuralgia has triggers, cutaneous triggers, and eating, brushing can trigger attacks. And there is a refractory period. So if you kept on triggering, so for example, if eating triggers the pain, if they kept on eating, after some time the attacks will stop for 5-10 minutes. Sangtan Suna is commonly misdiagnosed as trigeminal neuralgia, and in Sangtan Suna there is no refractory period, whereas in trigeminal neuralgia there is a refractory period. So that is one way to differentiate between the two. So the main mode of treatment for trigeminal neuralgia is carbamazepine and oxcarbazepine. You can use these other treatments as well. For patients who are in crisis, you can use IV phenytoin infusion, like 250 milligrams, a single dose as an infusion. Right, one more case. This is a 46-year-old male patient with no previous history of headache, presenting with sudden onset headache, a new onset headache 1 week after holiday, which involved some adventure sports, zip lining, and things like that. So patient doesn't have any headache when they wake up in the morning, but it's worse during the day. When they stand up, the headache gets worse, and when they lie down, the headaches improve. What is the most likely diagnosis? See what you think. The headache gets worse when they're standing up, improves when they lie down. Yeah, so the majority have got it correct. Correct. Most likely diagnosis is spontaneous intracranial hypotension. So that brings us to pressure headaches. So one of the commonest ones is more commonly encountered pressure headache is idiopathic intracranial hypertension, which I think most of you know. It usually occurs in young females who have a high usually occurs in young females who have a high BMI, and the headache gets worse with valsalva maneuvers and when they lie down, and they can also have a pulsatile tinnitus. And with valsalva maneuvers, their vision becomes they get like visual blurring for 30 seconds to 1 minute. So that's called transient visual obscurations. And when you examine, they have papilledema, and there are no focal signs except maybe sixth nerve palsy, which is a false localizing sign. So if you suspect idiopathic intracranial hypertension, the patients you need a lumbar puncture to measure the pressure and confirm if it is high intracranial pressure. But before doing that, you need to do a CT head and a CT venogram to exclude a structural lesion and also cerebral venous sinus thrombosis, which can give rise to IIH. And when measuring CSF pressure, the patient has to be lying down. If you measure the pressure sitting up, that is incorrect. And that value is, you can't interpret that value, and the LP becomes completely useless. So make sure that the patient is lying down when you measure the pressure. So treatment is mainly weight reduction and medical treatment. You can use acetazolamide. Can go up to 4,000 milligrams, but there are a lot of side effects when you go up to that dose. Usually you start at 250 milligrams twice a day and then increase depending on how the headache responds. And topiramate can also be used, which can also help with the weight reduction because of the loss of appetite as a side effect. And if there are very high, it's a very high opening pressure with high risk features with significant papilledema, problem is the patients can lose their vision. Because of that, we can do serial lumbar punctures to bring down the pressure, and you can refer to the neurosurgeons. They can do a shunt or drain to normalize the CSF pressures. The opposite of that is what we had in the previous case. So that is intracranial hypotension. So in this situation, the CSF pressure is low, usually due to a CSF leak. Now, we commonly experience this after lumbar puncture when the patients get a low pressure headache, which improves. When it happens spontaneously, it's usually due to a leak, which can happen due to either AV fistula, dural AV fistula, or sometimes when there are degenerative changes in the spine, there can be bony spurs, which can pierce the dura, which leads to CSF leak. So the patients will say the headache is better when they're lying down and gets worse when they stand up. You should say when they wake up in the morning, there's no headache, but after they've been upright for some time, they start getting the headache, which worsens if they stay upright. And when you do an MRI scan, you can see that the midbrain is kind of slumped. There can be enlarged pituitary gland. You can see subdural collections, meningeal pachymeningeal enhancement as well. And when you do the MRI of the spine, you can see epidural fluid collections. And treatment is you can do an untargeted blood patch, but most of the time these patients need a targeted blood patch, which is done by interventional radiologists. And if it is a big leak, some patients sometimes need surgical treatment as well. So if you suspect an SIH, you need to refer the patient for further assessment, including MRI scans, and then they can decide further treatment. Right. Another common scenario we have is when patients present with headache in their pregnancy. It becomes a problem because the question comes whether to do imaging or not to do imaging. So there are three common scenarios when patients present with headache in pregnancy. So it can be a patient who has a diagnosed primary headache disorder like migraine, who presents with the same type of headache. They will say, this is like my normal headaches. And in these patients, you can carefully decide not to image them, but you still have to be very careful. But if it is a patient who has a primary headache diagnosed before, but now comes with a different intensity or change in the phenotype, then these patients need imaging. And similarly, if it's a patient who has not had a previous headache diagnosis comes with the first presentation of headache, these patients also need imaging. Now, the things that we worry about in pregnancy, there are a lot of things, but commonest things that we look for are eclampsia and preeclampsia. Cerebral venous sinus thrombosis is quite common problem in pregnancy. And also with high blood pressure, they can get reversible posterior leukoencephalopathy syndrome of PRES as well. And some cysts and tumors can increase in size during pregnancy as well. So these things we need to be careful about. So when it comes to treatment of migraine in pregnancy and lactation, for acute medication, paracetamol and triptans can be used in pregnancy and lactation. NSAIDs are not safe in pregnancy, except in second trimester. You can use carefully. NSAID can be used in lactation. Aspirin is not used in pregnancy and lactation. When it comes to prevention, during pregnancy and lactation, you can use propranolol, amitriptyline, magnesium, and nerve blocks are also quite effective. There is doubt about botulinum toxin. Some centers use botulinum toxin, but generally it's safer not to use it. CGRP treatments are probably safe, but we are still not able to use them because of the lack of data. So hopefully in the future we might be able to use it. Topiramate, valproic acid, and candesartan are not used. They are not safe in pregnancy. And fluorescein and pizotifen can also, again, we don't have enough data. I put this link, uktis.org, which has information about heterogeneity of different medications. So if you can search by medication, so that's a quite useful resource when you want to see if a medication is safe in pregnancy. So this is briefly about treatment of migraine in pregnancy and lactation. Another situation is headache in the elderly. So in elderly patients, you have to look for all the other red flag signs because of the risks like vascular risk factors, cancers, tumors. So these things you need to be mindful about. In addition, one more extra thing you need to think about is giant cell arteritis. Because if you miss this, that can have an effect on their vision. They can lose their vision as well. So in a patient who's of the age of 50 who presents with new onset headache or changing characteristics, if they have visual disturbances, especially if it is a monocular vision loss, and if they have jaw claudication, systemic symptoms, think about giant cell arteritis. You can do an ESI and CRP, and if you suspect, you need to do a Doppler of the temporal arteries and a biopsy if needed. And the treatment for this is steroids, which needs to be started early in order to prevent vision loss. Right. I think that brings me to the end of my talk. There are many other types of primary headaches, which I didn't go through and only discuss the common things that we see. So take-home messages. In headache, history is very important. Especially, you need to dig deep into the history, the onset, to make a phenotypical diagnosis, which decides which your treatment options and the investigations. Thunderclap headache is abrupt onset, severe maximum headache, which is maximal within the first minute. So if you suspect a thunderclap headache, do a CT head. If the CT head is normal within 6 hours, you don't need to do a lumbar puncture routinely. But if it is done after 6 hours, you need to do a lumbar puncture to look for xanthochromia. Migraine, use preventives if they have more than 3 to 4 attacks a month, and don't just leave them on the same dose for months and months. Check their response and up titrate, and then change to a different one to find a medication that works for them. And be cautious about medication overuse headache. Opioids are generally not useful, so try not to prescribe opioids. And the best way to manage medication overuse is to optimize the preventive medication, and then while doing that, gradually cut down on the use of acute medication and advise the patient about the risks of medication overuse. Think about TACs. If a patient presents with strictly unilateral headache with ipsilateral cranial autonomic symptoms, which are short-lasting, and if you suspect a TAC headache, refer to a neurologist. And headache in pregnancy, consider investigating if it is a new or changing phenotype. And I think that's it. Hope I haven't confused you even more than before. I'm happy to take any questions.
Thank you very much, sir, for that interesting, informative, and interactive session. We have a few questions in the chat. The first one is, can we take flunarizine lifelong for migraine prevention?
Now, there are some problems with flunarizine. One of the side effects of flunarizine is that it can cause extrapyramidal symptoms like Parkinsonian syndromes. You can take, but you have to keep an eye about the side effects. So it can cause low mood, depression, and the other common thing is one more serious side effect is Parkinsonian syndrome, Parkinsonian symptoms. So that needs to be looked at. But you can keep taking them as long as they don't have side effects.
Thank you, sir. The next question is, what is the drug of choice for abdominal migraine in children?
So that still would be the same way as migraine. I'm not very sure about pediatrics because I don't deal with pediatric migraine, but I assume it would be the same as managing migraine. I think pisotifan is quite used in pediatric population, but I think that would you need to check probably with the pediatric neurologist. I'm sorry about that.
Thank you, sir. And then there's a request to tell a little about primary stabbing headache.
So primary stabbing headache. In primary stabbing headache, you have very sharp stabbing pain lasting maybe a fraction of a second, and they tend to occur. It's not in one place, so it can be anywhere in the head. And usually, we see that primary stabbing headaches are more common when you have some other primary headaches. So, especially patients with migraine, they will say that they have these stabbing headaches here and there when they even when they don't have migraine attack. For primary stabbing headache, we don't necessarily treat them because they are uh, very brief, infrequent attacks. But if it is uh, very frequent, you can try indomethacin as well. And we also sometimes we use this nerve in UK. We use nerve stimulators as well. But generally, because they are more associated with migraine and other primary headaches, you have to treat the underlying primary headache disorder, and that usually helps to control the primary stabbing headaches as well.
Thank you, sir. The next one is, if CT is negative within 6 hours of onset of headache, can we
Yeah.
exclude SAH?
So the current guideline, the NICE guideline is if the CT is done within 6 hours from the onset of the headache, and if it is reported normal by a radiologist, then you can say you can exclude SAH. But again, because these are clinical decisions, if you if you are very confident that this could be a subarachnoid hemorrhage, and if you're really worried about it, you can still go ahead with a lumbar puncture. But routinely, you don't have to do a lumbar puncture if the CT is normal within 6 hours. That basically says that the guidelines say that an SAH is less likely if the CT is normal within 6 hours.
The next question is, can sinusitis headache present as unilateral headache and pulsatile?
Yes, I guess pulsatility, I'm not sure, but it can be unilateral headache. But if it is sinusitis, then it would be around the sinus area. So most of the time, patients who are diagnosed as sinusitis actually have migraine at the background. So that the migraine becomes more prominent because of sinusitis. But I guess it's if it is around the area of the sinus, then yes. But do look for migraine because it's most of the time there is migraine at the back in the background.
Thank you, sir. The next one is, what is the best drug for prevention of migraine as lifelong treatment?
There's no single best drug, so we have to find a medication that works best for the patient. The new medications, unfortunately, they are not available in Sri Lanka. Those are quite good because there are no side effects. But out of the ones that's available in Sri Lanka, so propanolol and candesartan can be used as long as there are no side effects. Even amitriptyline can be used, but you'll have to monitor for side effects. There's no single drug that's best to take lifelong. So sometimes we often see that patients start a medication and it is effective, but then with time they lose the efficacy. Then we have to change over to a different one. So, but you need to find the medication that works for them, and you have to keep monitoring for side effects.
Thank you, sir. The next one is, does postcoital headache considered as a red flag?
Yes. So if so, that's called primary headache associated with sexual activity. So in a patient who's presenting with postcoital headache or headache around sexual activity, you need to do a CT MRI head with an angiogram. So you need to look for aneurysms, vesicle malformations, dissection, those kind of things. You need to first rule out. So once you rule that out, then you can treat it as a headache associated with sexual activity. And the treatments, usually you can give a triptan or indomethacin about 1 hour, 1 to 2 hours before the expected sexual activity. But you need to rule out any structural cause first, including an angiogram.
Thank you, sir. And the last question is, for migraine in pregnancy, are there any medications which we are not using during pregnancy and lactation?
Uh, yeah, I think I put the slide there. I'll share it as well. So in pregnancy and lactation, for prevention, you can use propanolol and you can use amitriptyline. Um, those are the ones that we normally use. And you can use magnesium, which has some kind of modest migraine preventive effect. And safest in pregnancy, one of the safest is nerve blocks. If you can do a greater occipital nerve block, the effect can last about 3 months. So during the pregnancy, 1 or 2 inject nerve blocks we can manage, but that needs to be done by someone who is trained to do it. But if you look for oral medications, propanolol can be used, but you need to be careful about neonatal bradycardia. Amitriptyline is also used. They say it's safe in pregnancy, and the amount secreted in breast milk is not enough to cause any problem. So it's safe in breastfeeding as well. Those two are the safest ones.
Thank you very much, sir. That brings us to the end of the session. And I have just a suggestion.
Yeah.
Because as a primary care physician, we have done few studies in the outpatient departments, and
Yeah.
headache is one of the top 10 symptoms. Uh,
Yes.
so
Anywhere in the world, I think.
yes, and the way our patients describe the headache is, I think, far more different from whatever is available
Yeah.
literature in the Western world. I would like to just give a suggestion to do a study like, since now there are large language models and we can record the way patients tell about their headache, and then
Mm.
maybe decode it and uh, do something like screening, so that whether the patient should reach the doctor or whether they can take some analgesics. Uh,
I think there have been, but most of them are in English, so they wouldn't apply to the Sri Lankan population, I guess, because of the language difference. But I think there have been some studies where they've looked at screening through language models, but I don't think there's anything that kind of uh, approved for day-to-day use. But I think there have been studies going on. But if someone in Sri Lanka can take the initiative, that would be a good thing to do, especially if you can do it, taking our language in the way that our patients describe it.
yes,
I'm
yeah.
not. I don't think I'm tech enough to look into AI models.
No, we do have the groundwork first, and
Uh-huh.
AI also we have some experts, but what we need is the guidance and of course the funding. uh, Maybe now the
I think
NIH.
if someone is interested, if you speak to maybe some of the neurology consultants in NHSL, they would be quite happy to help with any research activities.
Yes.
They might be able to help with funding as well.
Yes, sir. So thank you.
Because I work with Dr. Bimsarasena Naik, and sir is very helpful. And sir is quite a lot. He does a lot of research work. So if someone is interested, sir will probably be happy to help.
Yes, yes. Thank you very much, sir. Thank you for
No,
that interesting session. And as always, Sri Lanka College of Specialist Family Physicians are trying to uplift the primary care services and delivery. And you have helped a lot with this session. And we look forward to meet you again in the future with more sessions like this. Thank you very much. And thank you for all the participants. I think till the start of the question session, we had more than 150 participation. And I would urge the participants to fill the feedback to receive the certificate. Thank you very much and look forward for future sessions with you.
thank you very much. Thank you.